Good afternoon. It's a pleasure to be here at the AAO. My name is Renato Parsekian. I'm from Araraquara, Brazil. I took my training as an orthodontist in Brazil, except for a period of time that I spent in Dallas with Dr. Busheng at Baylor, now Texas A&M School of Dentistry. And I would like to thank the scientific committee, especially my good friend, Carlos Flores Mir, for inviting me to be here. So this is a slide of the conflict of interest that we are supposed to have. I'm a key opinion leader for orthodontics in Brazil, which is distributed in the USA by Specialty Appliances. And I'm co-founder and co-owner of Ortho Emotion, which is an aligner company in Brazil, which uses Archform software, an industrial version. So, of course, you're going to see a little bit of the Archform software in this lecture, but none of it is commercial. So today, we need to start talking about mechanics, and specifically comparative mechanics between braces and aligners, and specifically in vertical problems. But today, I don't have enough time to talk about deep bites and open bites, so I'm going to focus this presentation on open bites. So last year in Chicago, we spoke about the correction of open bites and the side effects that we have whenever we're extruding the anterior part of the arch, which of course can be done. We can close bites doing bends, but due to equilibrium, and here you can see the step bends that we placed on this arch wire, we end up proclining the posterior teeth and the anterior teeth. This is a side effect of doing sequential step bends when we're trying to close bites. And it doesn't matter if you're doing the bends, and it doesn't matter if you're bonding the brackets higher in the anterior part. The side effect of a step geometry is always going to be proclination, anterior proclination and tipping of the posterior teeth. And this can be frustrating because if this wasn't planned initially, if you didn't want a proclination of the incisors, you're going to end up having that in your patient. And there are several ways of managing this. We talked about this last year. A very good way is to use anterior box elastics. The Mial techniques uses it very well. And the reason is because if you apply a vertical force anterior to the arch wire, as you go forward and very distant from the center of resistance of the arch, you're going to get a large distance and a tipping moment in the whole cant of the occlusal plane, and that of course can help you managing the proclination. So whenever you're doing step bends or trying to close anterior bites, it's a good idea to use anterior box elastics. Even if you use reverse curves, which you can with night tie, it's a good idea to use the open box or the anterior box elastics in order to close the bites. So pretty much we can manage to close bites with fixed appliances if extrusion is allowed in the anterior, like it is with this kid. He didn't show too much gingiva in the beginning, but in the end it's a little bit better. And we can notice that if we use this anterior box elastics in reverse curves, we can close the bite mainly with extrusion of the anterior teeth. So here before and after. So I invite you to review this lecture after you see this one. You can go back online and see the lecture of last year. But now we're going to talk with aligners, and we do need some sort of analogy. And there's a great challenge in treating open bites with aligners. And why is that? First, the literature tells us extrusion is the most difficult movement to control. Extrusion is the least accurate movement, and median vertical correction is around 1.5 millimeters. It means that most of the cases you're going to be treating, you're going to have 1.5 millimeters opening or deepening the bite. This is a very good article from Khosravi, and you can see the clinical data that shows the vertical correction is very limited with aligners. The overbite results are dependent of the pre-treatment overbite. So for example, if you have a 0 millimeter overbite initial, your final is going to be 0.3. If you have 1 millimeter overbite initially, final is going to be around 1. If you have initial 3 millimeters overbite, final is going to be 2. If you have initial 6 millimeter overbite, final is going to be 4. So if you have a tendency to open a bite initially, your patient will finish with an open bite tendency. If your overbite is normal, you're going to finish pretty much with a normal overbite. And if your initial overbite is large, you'll finish the case with an increased overbite. This is what the clinical data shows us. It's not the opinion of anyone. And it is different from what we expect with fixed appliances, where regardless of the initial overbite, we expect the case to be finished around 2 millimeters of overbite. So if you have your patient with an initial 0 millimeters of overbite, you expect the final to be 2 millimeters. If you have 1 millimeter of initial overbite, you expect the final to be 2. If you have 3 millimeters initial overbite, you expect the final to be the same. And even if you have a very large overbite, you expect to finish with a normal overbite. The boards all over the world, the American board, the Brazilian board, they expect you to finish with a good overbite regardless of the initial overbite. So fixed appliance appears to be a little bit different than aligners. And by the way, this graph isn't from the article, it's just a discussion that I'm bringing up to you. So apparently, we are limited to control vertical with aligners. So what is the issue with extrusion and aligners? Well, the first issue is that the aligner must pull the tooth from the same direction it engages. So it has to be flexible to fit, but it cannot be too retentive to be removed. Because if the patient tries to fit the aligner, and it fits very, very retentively, it's going to distort once the patient pulls it out. So there has to be an equilibrium. The second issue, it's because due to the plastic deflection and the attachment design, the force direction is not appropriate for pure extrusion. So we have here a simulation of what happens when we fit an aligner in, and we can observe the deflection of the plastic. There's a small lack of adaptation whenever you fit an aligner in and you try to extrude the teeth. So, and we can also see that the way that the aligner is going to fit over the attachment, the forces are not going to be parallel to the axis of the tooth. They're going to be somewhat lingual, or with a lingual aspect of the force. So here you can see from an article that we published in Brazil, a picture of a passive aligner on the right side, and an aligner activated with 0.1 millimeters of extrusion. So there's a little loss of adaptation in the cervical. You can see the aligner that is touching the attachment, but the direction of the force is not only extrusive, but is also lingual. And it doesn't matter if you increase the area of the attachment. So this is also the reason why we do not use attachments with a 90-degree beveled angle, because there's a distortion in the plastic once you get it engaged, and it's going to be touching only one small surface of the attachment. And moreover, it's going to be pushing the teeth lingually as well. So this is also the reason why we use beveled attachments rather than a 90 degrees attachment. So this is the reason. The reason is that you cannot apply a completely vertical force. And you may ask me, well, why don't you put another attachment lingual? It's because you're going to increase too much the retentivity. It's going to be too retentive. And it's not going to fit properly once the patient tries to engage it. And if the patient finally gets an engagement, once it removes, it's going to distort the aligner. So that's the reason why you see so many bootstraps around, especially on laterals and especially on canines. Because those are teeth that we sometimes when we do the planing, we want to extrude them following the long axis of the tooth, and it's hard. So these mechanics, they might tip the teeth lingually and push them towards collision. So you're trying to extrude a tooth, and if the mechanics is trying to lingualize that tooth, you might end up with some collisions that's going to keep the tooth from extruding. So there's a representation here of a normal bootstrap that we normally use, and we normally bond the buttons from the buccal. In the direction of force, being away from the center of resistance and having a lingual aspect of a force is going to force those teeth lingually. So there's a tendency not only coming from an attachment, but also if you do some auxiliary mechanics with a bootstrap, if you bond it from the buccal, it's going to bring the tooth towards collision. A better idea is to use it lingual going buccal. So you bond the button on the lingual aspect of the tooth, because then the load system is going to pull the teeth away from collision. And that, for me, is a better idea. Even when you're using inter-arch elastics, the same thing will apply. So I suggest that we always use a force coming from the lingual to the buccal. And that's going to bring the tooth that you want to extrude away from collisions. And this is an example. This is a girl that I treated in my office, and I tried for a long time to bring the canine and extrude the canine down, bring it down, using intermaxillary elastics coming from the buccal aspect of the canine. And the furthest I got was here, but of course you can also see that we need a little movement to the buccal of the canine as well. I could only be effective moving that canine once I change the mechanics, and once I place the force from lingual to buccal on the canine. And this is where we got. And of course, I wanted to extrude it a little bit more, but at this time, this picture shows an issue that we probably have all over the world with aligners, right? Because once you get to the chief complaint of the patient and you take care of it, the patient wants to remove the appliances. They just drop out of treatment. So you probably have the same issue, right? So this is the daughter of a good friend of mine. I really, really wanted to bring the canine down. She said, "Uncle, no, treatment's finished." And we have a third issue. So the third issue is that we may have during treatment two components of extrusion, which may confound the previsibility of the result you're getting. And for that, I need to explain you something. I need to explain you the three classes of movements with aligners. We also published a paper on this. But for today, I'm only going to talk to you about the synergic class of movement. The synergic class of movement, it's very similar to what we talk about in fixed mechanics and we call a consistent force system. It's when the force and the direction of the side effect of the force are what you really want or are your objectives of treatment. So for example, if you're going to try to extrude a central incisor, the force being away from the center of resistance is going to extrude that tooth and it's going to rotate it around the center of resistance. So in this case, it's going to tip that tooth lingually. If you want a lingual tip and if you want extrusion, we are talking about a synergic movement. Both are in the same direction that you want. Well, when you retract, it's the same. If you're retracting an incisor, and here I'm drawing to you with the center of resistance depicted by the yellow dot. You see that you get extrusion, relative extrusion of the incisal edge, but there is no true extrusion. You can see that the center of resistance is at the same level. So this is a synergic force system. It means that whenever you're having retrusion of incisor with aligners, there is always a tendency of deepening the bite. Or whenever you want to deepen the bite, you're always going to get a tendency of lingual tipping. That's a good way of putting it. And the opposite is also true. If you have crowding and you're pushing teeth away, you're going to get an opening of the bite, which is relative of the incisal edge, even though the teeth is not intruding, because the center of resistance is at the same level. So we have a component that comes from retroclination, which can close a bite, which is very reliable. Because if you look at the literature, you're going to see that tipping is one of the movements that are very, very reliable with aligners. So buccal tipping and lingual tipping are very reliable. And you get extrusion or intrusion of the incisal edge relative to the incisal edge whenever you do those two movements. And you can use that in your favor, or you can predict the reliability of your treatment if you can observe this. So let me show you a picture, a case of a patient. So her chief complaint was that she had proclined incisors. There's a line that I like using a lot to evaluate proclination of incisors, and I invite you to look at an article that we published in the Seminar of Orthodontics in 2022. It's a modification of the diagnostic line proposed by Dr. Andrews. So roughly, it's a line that's parallel to the face of the patient passing through glabella. So the crown of the upper incisor should be parallel to that line, and the incisor in the AP direction should be around where the line is. So this is a very easy way to predict a good position of upper incisors. And this matches with the chief complaint of that patient, that she believes there's too much proclination. So her central incisor is not too far forward, it's just too tipped buccally. And she also complains a lot about the canine. So her right upper canine. So we have a mild, very small class 2 on one side and an end-on class 2 on the other. And I'm going to treat her only with IPRs in the upper arch, posterior IPRs and anterior lower IPRs. And we can notice that only by proclination we close the bite a little bit. So there's no extrusion, there's no pure extrusion planned here. It's only relative. Here, of course, the correction is small, so you can see it very well. But on the other side, if you look on the end-on class 2, and you focus your view on the incisors, you can see that we got approximately 2 millimeters of deepening of the bite, but there is no true extrusion here. It's only relative. So you can incorporate relative extrusion whenever you want to close a bite. You just need to do posterior IPR. So here's the result before she went to do the finishing cosmetic on her incisors. This is what we got retracting them. So her incisor is parallel with the face. And we can check the extrusion that we get, relative extrusion of the incisal edge. And we need to separate it from pure extrusion, which is unreliable. So pure extrusion, which is this, is very unreliable to get with aligners. And it's difficult because of the reasons I told you: attachment, direction of force, and the flexibility of the aligners. So you have two components, one which is reliable and one which is not reliable. And here's a good example of a case that I treated where this patient had a crossbite around the region of the lower right canine, and it was a little class 3, and we had retraction there, and we had lingualization of the canine and incisors. Look how in the right side, where I had tipping, lingual tipping of the canines and the incisors, the vertical correction was a lot more than on the other side. So in the upper left lateral, I had programmed pure extrusion. It never happened. But the relative extrusion in the opposite side of the arch went very well. So I need to know this. So how can you tell? If you have your case, after you do your setup, you can measure how much there was of extrusion of the incisal edge. So here I'm using the arch form. You can check that we had an extrusion of the incisal edge of 0.9. I can go on my numbers and I can see the pure extrusion, which is 0.24. And now I can check. I have a total extrusion of 0.9, out of which 0.24 is pure extrusion, which is not very reliable. And what remains, which is 0.66, is extrusion of the incisal edge that's only relative. So 0.66 is reliable, 0.24 not so much. And this is a healthy criticism that I have to make to the researches that we are having today that measure vertical with aligners. They put everything in the same bag, which is the extrusion which is pure and the extrusion which is relative to the incisal edge. And we cannot put them in the same bag. We need to measure them separately. If you don't use Archform and use Invisalign, you can check. Today, they have the values of extrusion, pure extrusion, and relative extrusion, and the tipping. So you can relate to those. And you can see which part of your movement is reliable and which part is unreliable. So again, pure extrusion is not very reliable. Relative extrusion is very reliable. So, but what happens if I want to extrude from canine to canine, pure extrusion? Well, let me show you a case. Maybe you can find out. This is a vertical patient, class 2, open bite, and she's a surgical case. So whenever I want pure extrusion of the upper dentition, probably I'm going to need orthognathic surgery. So I'm going to prepare the case with aligners, and I'm going to call your attention to this little setup video. Observe the upper right lateral. It's going to extrude by itself. There's pure extrusion on that lateral. And we're going to talk about this lateral in a little bit. So she went on with 12 pairs of aligners, roughly. She used them very well. She was living in Portugal, and I was treating her away in Brazil. So I saw her 1 or 2 times only after we finished, before and after we finished this first set of aligners. And everything went well. So what I do? I took a scan, printed in my little printer in my office, and I could fit very well the occlusion. So that means I can send her off to have the surgical procedure. But look at the lateral. The lateral is still there. It never extruded. And at this time in Brazil, the surgeon that I work with, one of the surgeons that I work with, had not yet done surgery without brackets in aligner cases, so he asked me to bond brackets. So I used an indirect system. I bonded the brackets in the patient Friday, and she went to surgery Monday. So this was just a request of the surgeon. And this is her after 15 days. So the lateral is still there. It didn't come down with the preparation of treatment with aligners. Everything else went well. Everything else but the extrusion, which was pure. This is what happened to her post-surgically. She got a rotation of maxilla and mandible counterclockwise. And she came back to the office and she wanted to finish treatment with aligners, and she could not open her mouth. I could not fit the scanner. So I told her, well, once you can open her mouth, we can go back to aligners. And it took her 3 months to be able to open her mouth so I could scan it. And by 3 months, I had already done the bend that I needed, and she was ready. So I ended up finishing her case in 11 months, 3 months after surgery. And I never went back to aligners because by the time she could open her mouth, the case was done. And and of course, I extruded the lateral using bends. So pretty good result. It's her after, before, here, and after, 11 months of treatment. But I could only bring the lateral down with fixed appliances. Now, what if I want extrusion and proclination? Because I told you that extrusion will produce lingual tipping. And that's easy to do with aligners. I showed you a case with pure extrusion, which is kind of tough to do with aligners by themselves. And now there's a tougher case where you need proclination and extrusion. That's something we call a load system that's antagonic. It's the opposite of a synergic. So whenever you push the tooth buccal, it's going to intrude. But what happens if I need extrusion? I can stay with my aligners for months, do several refinements, maybe I can get to a result. But you can come to your patient, like I did, and you can propose 3 or 4 months of fixed appliances before aligners. That's what I've been doing in very tough cases. So this girl, I wanted to extrude her central incisors because she doesn't show them very well. And when I looked the lateral ceph, and I used the same line parallel to the plane of the face, coming down from glabella, the buccal aspect of her central incisor is not parallel, so it's retroclined. So what do I want in her case? I need to extrude that central incisor and I need to procline it. That's very hard to do with aligners. So I sat down with her and I asked her, can you give me 4 months of ceramic brackets and then we go to aligners? She said, well, 4 months, I can deal with that. So what did we do? We bonded ceramic brackets, and it's very important because you need to be very objective and very fast here. You need to bond everything with overcorrections. Rotations, vertical movements, and you have to do everything in those 3 or 4 months. You can notice that she has hooks, so they're night-tie pieces electrically welded into her first arch wire, and she's going to use open anterior box elastics at the same time or right in the beginning of treatment. So this is month 0, ground 0. We bonded both upper and lower. This is 1 month. This is 2. This is 3. And I placed the band on the night eye rectangular. And this is 4. And she came 4 months afterwards to the office and she said, well, can I put the aligners now? I said, yeah. So I took everything out. But there was not much to do. In 3 months, she was done. So this is what we call hybrid mechanics. You need to identify movements that aligners are not very good to do, and you can substitute in a part of the treatment, which can be in the beginning or it can be during the treatment, with fixed appliances. That's what you should do whenever you know that aligners are not going to resolve a kind of movement that you need to obtain to finish a case of her patient. So again, in her case, we need proclination and extrusion. This is month 3. And this is her finished with the hybrid mechanics. So, our take-home message for today is that in treatments with braces and with aligners, we must understand the mechanics applied, and we need to observe the deflection of the arch wire and the plastic. Extrusion with fixed appliances, they tend to procline incisors, while aligners tend to retrocline them. This is a very good point to remember. Pure extrusions, they may need assistance from elastics, in my opinion, 100% of the time. And whenever using elastic mechanisms or mechanics, we should use the elastic moving the teeth away from collisions, interarch or intra-arch collisions. And also, another very important tip, whenever you're doing pure extrusion, if you choose to do it, always try to extrude the teeth by itself. Stage it. Do not mix it with rotations. Do not mix it with other movements. Use the extrusion by itself. So I hope you enjoyed this presentation as much as I did, and thank you.